Hi, I'm Cush with the Baylor Research Institute talking about adult onset Still's disease. In this segment, I'm going to talk about the manifestations of this condition and show you some pictures. To review, adult Still's disease is a systemic inflammatory disorder that typically affects young adults, usually before the age of 35. It has quotidian or spiking fevers, usually greater than 102 degrees Fahrenheit or 40 degrees centigrade, evanescent rashes, a polyarthritis, a prodromal sore throat, pleuritis, pericarditis, pneumonitis, hepatosplenomegaly, a leukocytosis, and very high sed rate CRPs and ferritin levels. There is no diagnostic test, however, and hence this can be a diagnosis of exclusion, and hence it is a syndrome. Its condition is, over time, is marked by either systemic flares of fever, rash, and arthritis, or once the systemic features die down, there can be a chronic arthritis that will ensue in a third of patients. There's often long disease-free intervals in these patients. So if we look at who gets this condition, we can see that this is a condition of young adults. 76% will have the onset of their condition before the age of 35, half of these being males and females. The condition after the age of 50 is really quite unusual. Less than 9% of people having the onset of this condition after age 50. There have been cases reported as late as 84 years of old being an age of onset, but again, the older the patient, the less likely you should be considering Still's disease. Again, it is the quotidian fever that really stands out. The fevers are very high. They're very debilitating to the patients. They tend to occur late at night or late in the afternoon, and they recur like clockwork, meaning it happens almost at the same time every day, almost to the minute. And the syndrome begins with shaking chills that will last for up to an hour or two, followed by a high fever spike that can last up to 2, 3, 4 hours. And then as they defervesce, they'll have drenching sweats. All this will happen in the middle of the night while the patient's often in the hospital or at home. And then on rounds in the morning, if the doctor sees the patient at 7 a.m., they look fine and their temperatures are normal because they often will have changed their sheets and showered and whatnot. But again, it is this reproducibility of the high spiking fever that occurs daily, often with a return to baseline or normal, that makes this distinctive. Again, I'm showing here the quotidian pattern where it goes up to 104 and then returns to normal late in the day every day. If you have a double quotidian, you have the twice daily spike, usually occurring at Q12-hour intervals. There are other things that give you high fevers in rheumatology that would include not only Still's disease, but septic arthritis, opportunistic infections, polymyalgia rheumatica, and even vasculitis. Low-grade fevers are much more common in the rheumatic conditions, in lupus, early onset rheumatoid arthritis, even gout or vasculitis. Usually the fevers are low-grade and don't have the same periodicity or regularity to the fevers that you see in Still's disease. So again, here you're seeing the fever pattern of someone with systemic onset juvenile arthritis where you have twice daily spikes that later becomes once daily spikes. Again, it's a double quotidian or a single quotidian fever. The next part of the triad being quotidian fevers and evanescent rash and polyarthritis, the second part of the triad is the rheumatoid or Still's rash or JRA rash as it has been called. It is characteristically evanescent. It comes and goes and will come out, especially with fever. My definition of evanescent means it changes more or less day to day or over a few days. It is usually salmon pink. It's faint. It's usually not bright red or violaceous, but it tends to be faint and maculopapular with areas of confluence. It likes to affect the trunk, neck, and extensor surfaces of the extremities. It is very, very rare in the palms, soles, or face. It has associated features of dermatographism and Koebner phenomenon. Dermatographism is an exaggerated wheal and flare at sites of scratching or trauma. Koebnerization is the reproduction of isomorphic lesions at former sites of trauma where the person has been scratching themselves, the rash will come out. Here's an example of a rash in a middle-aged woman where it's on her neck. You can see some of it has a linear characteristic suggesting she's been scratching herself, but it's sort of a faint red rash that does change day to day. This is also someone with a faint red rash on their chest due to Still's disease. Next, you see a woman, again, with the same pattern. Again, sort of the V-neck anterior chest is a typical spot for this rash. It's also the same kind of rash one gets with dermatomyositis, and one needs to look for features of myositis or muscle weakness or elevated CPKs in patients who may present with rashes like this. But with high fevers and this sort of rash and a change from day to day, that makes it really quite distinctive. And here's a young adolescent who actually has a protuberant abdomen and a linear streaky rash along the side, this is Kebnerization, where the rash has occurred in a spot where the person has been scratching themselves. So you're seeing the organomegaly of Still's disease, the rash, and the Kebnerization on this slide. So next is the polyarthritis, the last part of the triad. Again, monoarthritis, oligoarthritis really shouldn't occur. It should be more or less a symmetric polyarthritis. It likes to affect small and large joints. It may be accompanied by myalgias, just joint pain without swelling, or intermittent arthritis in a few people. 50% of people will have neck pain. Synovial fluid can be withdrawn, is often inflammatory. 50% will have carpal ankylosis, maybe 15% will develop tarsal ankylosis or cervical ankylosis. But erosive arthritis is the worrisome feature of this condition. It'll happen in 20 to 40%, or on average about 1/3 of patients. Often those people will be HLA-DR4 positive, and meaning that that's a gene that's involved in disease expression of their arthritis. Rare features would include tenosynovitis, periostitis, micrognathia, even myositis has been described in a few patients. But the hallmark articular feature of Still's disease is the carpal ankylosis. This is a patient from the University of Pittsburgh who starts out on the left with a normal carpus and normal intercarpal spaces, but over the course of 7 months develop a hazy, indistinct articular margins with those joint dark spots between the joints in the capitate or pericapitate distribution showing the effusion that occurs within the wrist of patients with active disease. So Metzger and Christie described in 1976 carpal ankylosis, meaning fusion of the wrist, that tends to occur in a pericapitate distribution. You can see the capitate fuses to the hamate, the lunate, the metacarpals 2 and 3, and even to the trapezoid bone, and that sort of makes that very distinctive. This rarely happens in conditions like psoriatic arthritis or rheumatoid arthritis. Is much more common in Still's disease. You can also get fusion of the ankle and the tarsal bones, but also in the posterior elements or the zygoapophyseal joints of the cervical spine. Often what drives the patient to see the doctor is not the triad features as much as the constitutional features. Again, 70% will have a prodromal sore throat, but often in addition to their fevers, they will feel very bad, have horrible fatigue, they'll lose weight rapidly, they'll have myalgias that'll be in their upper and lower extremities and large muscle groups. They will feel sick, nauseous, and sometimes have vomiting. Headaches, malaise, fatigue, and stiffness will often predominate early in the inflammatory systemic phase of the disease. As the disease progresses, you'll get involvement of the reticuloendothelial system. That would include generalized lymphadenopathy that occurs in up to 2/3 of patients. But it is the splenomegaly and hepatomegaly that occurs in 40% of individuals that is most worrisome. This is often paralleled by an elevation of hepatic enzymes in 70% of individuals. The hepatic enzyme elevation can be both a cholestatic or hepatocellular picture, so either one seems to work with this condition. Uncommon but worrisome is chronic liver disease. Hepatic failure has been described, especially in people who are taking nonsteroidals or salicylates, and even salicylate hepatotoxicity has been described in patients with Still's disease. Pleural, pericardial, and pneumonic involvement is not uncommon. It occurs up to 40% of individuals. So pleural, pericardial, and even pneumonic involvement is not uncommon in Still's disease. It occurs up to 40% of individuals with pericarditis, pleuritis, and even bilateral pneumonitis with hypoxia. So this is a patient of mine who has both pleural involvement, pericardial involvement, and pneumonitis. You can see that here is manifest as cardiomegaly with pericarditis, pleuritis, and pneumonic infiltrates bilaterally with hypoxia. These features are seen in up to 40% of individuals with active Still's disease. This person also had cardiomegaly and an endomyocardial biopsy showing myocarditis on the bottom right-hand portion of the slide. So again, cardiopulmonary manifestations will occur in somewhere between 20 and 40% of individuals. The myocarditis is quite rare. There are a number of other rare associations that have been described with this condition, and they're listed for you here. So those are the major clinical manifestations of Still's disease. In the next segment, we'll talk about the diagnosis and the use of laboratory in diagnosing patients with Still's disease.